Hello, everyone, and welcome again to our Frailty Seminar Series for 2024. I'm Dr. Ruiz Jorge. I'm Medical Director of Geriatric Medicine and Memorial Healthcare System in Hollywood, Florida, and I'm faculty at Florida Atlantic University in Geriatric Medicine. And of course, as usual, we're honored to have Dr. Cesari, Matteo Cesari, who has joined us before for our Frailty Seminar Series. And this time he's the sole presenter, and he'll be talking about intrinsic capacity. That is a very rapidly growing, term and concept promoted by the World Health Organization and maybe other academic institutions around the world. So, but before we give a brief introduction to him, I just want to remind you that if you have to ask questions, please use the chat feature of WebEx. We'll try to answer as many questions as we can at the end of the talk. And remind you that next Frailty Seminar Series will be in the May of June. I'll send the details about the speaker and in the announcements that you usually receive. But I don't want to take too much of the time, and I'm going to introduce Dr. Cesari. Let me get to this. And of course, he's currently at the World Health Organization in Geneva, Switzerland. He's a renowned scientist in geriatric medicine and gerontology. He's been in multiple high-quality, prominent healthcare institutions, medical institutions, and universities and College of Medicines in Italy and the United States. Most recently at the University Stegli Study di Milano in Milan. He's been involved heavily in teaching, research all over his career. He's been editor for multiple journals. He's currently the chief editor of the Journal of Frailty and Aging. He's been consultant, of course, for the World Health Organization even before he became part of it. Again, we were honored to have him in the United States, in University of Florida and other important healthcare institutions in the United States. He was a research assistant professor, most recently in 2007 and 8 in a big group, part of the University of Florida and the CREC there. And he was also Wake Forest University. And like I said, he's published extensively, I would say, probably one of the most prolific geriatricians in the world, with multiple high-impact papers, and again, publishing the best journals in geriatrics and medicine. So it's an honor to have him, and who else to talk about, an important topic to all of us, that is frailty, and of course, how that relates to intrinsic capacity, another important concept that we'll be discussing today. Thank you again, Matteo, for joining us.
Thanks a lot, Jorge, for the introduction, and it is really an honor and a pleasure to be here. And really thanks a lot for the invitation and giving me the opportunity to discuss about frailty and intrinsic capacity. Now, as you mentioned, I really spent many years working on frailty. During the past years, during my collaboration with the WHO, I started working in parallel also on this other concept of intrinsic capacity. And I would like in this presentation to discuss why the WHO has led this new concept coming out when there was already a frailty established construct on which we could have relied. But at the same time, I want to show the opportunities that we have, especially as geriatric workforce, given the large overlapping between the two theories, the two concepts. So I'm going to share the slides. Okay, frailty and intrinsic capacity. This is the theme of the presentation. I hope you can see it. I have no conflict of interest to declare. Now, I assume we are in the frailty seminar series, so I will not spend a lot of time discussing what frailty is. I mean, frailty has been defined several years ago, like 10 years ago, by a consensus paper published in JAMA as a medical syndrome with multiple causes and contributors that is characterized by diminished strength, endurance, and reduced physiologic function that increases the individual's vulnerability for developing increased dependency and/or death. When I present about frailty, I tend to use this consensus definition mainly because in the authorship we have the two major schools of thought in the field. Among the authors, there is Ken Rockwood and Linda Fried. So the theory, this theoretical definition is supposedly approved and validated by both. I will not go into many details, as I said, on frailty, but we all know that frailty is a critical condition for older persons. And it has already been recognized as an emerging public health priority. So frailty has an importance at the clinical level, but also for public health purposes, as it was discussed in this article, again, published in JAMDA several years ago. This was 2016. And in the list of authors, you can find, besides many geriatricians, also members of the WHO staff. Of course, the paper was published on an individual basis, but the aging and life course department at the time of the WHO co-signed this article showing a public health interest on the concept of frailty. Where is the problem here? We are all well aware about long-lasting controversy on the instruments for measuring frailty. These are just a couple of examples, a couple of papers showing how the agreement between instruments developed over the years for measuring this condition is relatively modest. The graph on the left side of the slide is showing that, I mean, the consistency in results across 35 different instruments is relatively low. And also when we look at one specific instrument, let's take the frailty phenotype, the graph on the right side of the slide. Very often the same instrument is translated into practice in different ways. This, of course, is challenging the comparability, the comparison of results across studies. There is an inconsistent narrative in the way the frailty definition, the frailty theory, is translated into practice. And this makes challenging for public health authorities sometimes to well understand what we are talking about as geriatricians. To show that the WHO has carefully considered the concept of frailty, I'm showing you a report from a meeting that was held in Geneva in 2016. The meeting gathered different geriatricians with international visibility and expertise. And in this document, summarizing the results of the discussion, it was shown how intrinsic capacity was potentially a predictor of frailty. It was something to be considered as a background biological status to be linked with the outcome of frailty. And it was also, there was also a large consensus at indicating the geriatric workforce, all the persons with competencies in geriatrics, as a critical asset for moving forward the agenda, the global agenda on healthy aging. In the same document, it was, however, stated that there is a need of precise definitions of frailty. There is the need of clarifying the existing controversies in the field of frailty before a global organization such as the WHO can completely and fully endorse the concept. Which is the problem of frailty? Again, there are other problems that we need to discuss about frailty. Frailty is more and more associated with a stigma, with a sort of discrimination. It is very different the way in which we talk today about frailty compared to some years ago. When the frailty phenotype was developed by Linda Fried in 2001, it was mainly built for giving visibility to some signs and symptoms that very frequently are undetected, are neglected during the clinical routine. Exhaustion, slow gait speed, weakness, sedentary behavior, and so, I mean, the weight loss. And the idea was to raise awareness about these neglected symptoms in order to introduce them in the clinical routine and build preventive strategies by having a more comprehensive approach to the older person beyond the chronological age, beyond the clinical condition, the diseases. However, as soon as frailty has started going beyond the perimeter of geriatric medicine, we have seen more and more frailty used as a criterion for excluding the older person from care opportunities. We have seen this very clearly during the COVID pandemic. Frailty very often has been used to exclude persons, older persons, from care opportunities, for example, ventilators, without understanding the inclusiveness, the inclusive meaning of frailty, that is a condition that should bring a multidisciplinary team around the patient in order to understand how risk factors, how condition can be reversed in order to offer care opportunities, or at least to develop a personalized care plan. Again, this is related to the stigma that frailty more and more has seen applied to it. Another issue of frailty, with the eyes of the World Health Organization, is perhaps the fact that it is very connected to the geriatric world. And I want to explain this more carefully. This is a common structure on how frailty is or should be managed. We conduct a screening for identifying older persons at increased risk of events, older persons with frailty, and once we have identified a frail individual, then the most immediate gold standard intervention is the conduction of a comprehensive geriatric assessment for the development, implementation of a personalized care plan. This structure, screening, identification of frailty, a comprehensive geriatric assessment for the personalization of care, is also mentioned between the lines in the well-established, well-known Cochrane database systematic review published by Ellis, where comprehensive geriatric assessment was defined as a specific tool that was aimed for the management of older persons with frailty. So frailty is linked to an intervention that requires special competencies, the capacity of approaching the complexity of the older person, and potentially also a geriatrician, a workforce that is specifically trained in geriatric care, that in many countries does not yet exist. Even in high-income countries, we often suffer from a shortage of geriatricians, geriatric nurses, the geriatric care workforce. And so having a concept, frailty, very linked to a specific specialty and specific intervention that cannot talk to the entire world might be challenging from an organization, for an organization such as the WHO that has the global level as primary target. In this context, we need also to consider this graph. We are always thinking at high-income countries as the countries where older persons are, live, and will be. Whereas already today, most of the older persons do not live in high-income countries. And by 2050, 80% of older persons will live in low and middle-income countries. And in parentheses, and linking this to what I was just saying, in low and middle-income countries, the presence of the geriatric workforce of persons that have been specifically trained in geriatric medicine is not so available as in our settings. So we have an emerging need of geriatric care, of a geriatric approach in countries that are characterized by poor competency in how to approach and manage older persons, and at the same time are facing basic needs in the access and delivery of care. This makes everything very urgent to tackle because, as you can see, the population, the older population is exponentially rapidly aging, especially in low and middle income countries. And we have also to start building, mainly from scratch, these capacities, these competencies in the most capillary and disseminated way as possible. Now, going to the World Health Organization and what has been doing on aging and the development of intrinsic capacity. In parallel with the discussions on frailty, the World Health Organization in 2015 published this World Report on Aging and Health. This was the first document in which the WHO was specifically talking about aging. And in this document, the WHO provided a definition for healthy aging as the process of developing and maintaining the functional ability that enables well-being in older age. So what is functional ability? Functional ability in this document was defined as the health-related attributes that enable people to be and to do what they have reason to value. It is the blue line, the blue trajectory in the graph at the bottom of the slide. Functional ability is composed by two components: intrinsic capacity, that is the composite of all the physical and mental capacities of an individual, and the environment, that is all the factors in the extrinsic world that form the context of an individual's life. You can find in the graph at the bottom, intrinsic capacity represented by the red line and the environment as the gap between the blue and the red line. Now, translating this into practice, I just made you an example to understand how this framework works. I like to read, and by reading, I get knowledge for my benefit and the benefit for persons who are in my community, in the society surrounding me. If I have a loss of intrinsic capacity, that is, for example, a vision impairment, my intrinsic capacity will decline, will be lower. If I have access to care, if I have access to the ophthalmologist, if I have the financial resources for buying the correct eyeglasses, then I will live in a favorable positive environment that will allow me to correct my impairment in intrinsic capacity and reduce the gap between my intrinsic capacity and functional ability, restoring the possibility of keep reading and learning for myself and the others, contributing to my quality of life, but also contributing for the well-being and the sustainability of the society where I live. If the environment is negative, the gap between intrinsic capacity and functional ability will tend to remain large, diverge. I will have an impact on my quality of life, on my abilities, and at the same time, the society may not benefit from my contribution. This is the framework as it is being shaped. As you can see between the line in this theory, we are not talking about diseases. We are talking about capacities, about something that is under our skin, so very close to the concept of frailty. And at the same time, we talk about the interaction between the organism and the environment. So something that talks again to the comprehensive assessment that usually geriatricians apply in their clinical routine. In this context, we have also to acknowledge the fact that the United Nations in 2020 proclaimed the decade between 2021 and 2030 as the decade of healthy aging. The decade of healthy aging are 10 years that are completely devoted to foster collaborations at a global scale to bring together the different stakeholders, the different sectors, from government to civil society to international organization, academia, media, also private sector, in order to work together for the promotion of healthy aging, for improving the world where we live and to make it a better place to grow older. As you can see here, there is another step forward. We talk about healthy aging, following also the report on aging and health. The narrative is very consistent because there is the need of introducing a positive meaning to the concept of aging. In the World Report on Aging and Health and in the Decade of Healthy Aging, that is just the follow-up of that, aging is characterized by a positive approach. There is every attempt to avoid a discrimination, a stigma to older persons, to the age-related diseases is tried to be avoided. The focus is on reserves, on capacities, on abilities, and we want to push forward a positive perspective to older persons and aging, trying to really reduce the ageism that is so pervasive not only in the society but also in the clinical setting. The Decade of Healthy Aging is based on 4 different action areas. How we can promote and achieve healthy aging? Well, the plan of action of the Decade of Healthy Aging is based on 4 main concepts. We need to combat ageism. We need to build and promote age-friendly environments. We need to integrate care, and we need long-term care. Long-term care, please be aware that when the WHO, the United Nations, talk about long-term care, they do not refer to the facility, to the nursing homes, but they refer to the vast, to wide spectrum of services allowing the continuum of care according to the evolution of the person needs, mainly for the management of chronic conditions. These long-term care services include rehabilitation, include palliative care, and may not be specifically conducted in an institution, but also, for example, at home and in the community where the person lives. Now, as you can see, the 4 action areas have a very inclusive approach. They are designed as 4 independent activities, but in reality, they are interacting one each other. And again, also in this plan, we can see ideas and works that the geriatric community have been pushing forward over and over during the years. There is the inclusiveness that we want to have when we approach older person. We see the need of acting in the environment where the person lives. We need to integrate care. We need a multidisciplinary approach, sharing experiences, expertise, perspective when dealing with the complexity of the individual. And we need to give a longitudinal perspective to the care plans that we want to put in place. We need long-term care. We want a continuum of care put in place to adequately respond to the evolving needs and priorities of the individual. One difference that we need to consider compared to the usual approach that geriatricians have been having in the field of frailty is that in this context, the primary healthcare setting becomes really a primary setting of interest. The primary healthcare is the cornerstone of every sustainable health system. And by providing training, building capacities at the primary healthcare level on how to approach the older person, how to manage the basic needs and priorities of the older person, we may have a more disseminated approach, a more disseminated quality care offered to this population, and in a sustainable way. And at the same time, we may also better benefit from the potentially limited, when available, presence of geriatricians and the geriatric workforce. In countries where geriatricians are very few, they may then become the trainers of the workforce, considering that today older persons are in every setting and everywhere with their clinical and social complexity. The first step that was taken after the development of the theory of intrinsic capacity, the framework on healthy aging, was to deliver guidelines on how to manage declines in intrinsic capacity. This is a publication that was released in 2017. And it was including a set of evidence-based recommendations that could directly allow to intervene on intrinsic capacity decline at the community level. So there is the framework that was presented in the World Report on Aging and Health, the framework of healthy aging with the introduction of intrinsic capacity. The first step was then to identify in the literature what can be done by the health and care workers to address the impairment of intrinsic capacity. In this context, in this document, a set of different recommendations were provided on the basis of the available evidence. And please consider in this case that when I say evidence on intrinsic capacity, is largely evidence coming from the many works that geriatricians, researchers in geriatric medicine have been producing in specific domains of the health status of the older person, but also in the field of frailty. As you can see, intrinsic capacity that is structured across 6 different domains: locomotion, cognition, vision, hearing, psychological domain, and metabolic or vitality domain, can be translated into impairments that have usually been targeted by interventions in geriatric care that are very well validated in the scientific literature. And for example, when we talk about managing the decline of intrinsic capacity for the locomotor domain, we mean encouraging multimodal exercise. When we want to tackle a decline in intrinsic capacity due to undernutrition, to the so-called vitality domain, then we have evidence showing the benefits from providing dietary advice and eventual oral supplemental nutrition. Similarly, the correction of vision and hearing impairment has clearly been shown as effective in the management of these domains of intrinsic capacity from the literature that geriatric research has been producing over the years. And for cognitive domain and for psychological domain, we have evidence-based interventions, again, suggested how cognitive stimulation and how psychological interventions might be beneficial for the older individual in these domains that are composing the intrinsic capacity construct. In the same document, there were also additional evidence-based interventions that were pointing at urinary incontinence, at the management of urinary incontinence, at the prevention of falls, and at the support of caregivers. Again, these are guidelines based on evidence for tackling all these age-related conditions, these very highly prevalent conditions of old age at the community level. In other words, and linking to what I was saying before, these are relatively simple interventions that may require some clinical expertise, but may not really need a geriatric competency, that may not need a geriatrician to be there for being allocated in and promote a preventive strategy, especially when these are applied at the primary healthcare level. After the development of the guidelines, the World Health Organization, always around the concept of intrinsic capacity, developed this ICOPE implementation framework. ICOPE is the acronym of Integrated Care for Older People. And in this guidance, the WHO explained that to tackle intrinsic capacity and functional ability in the promotion of healthy aging, we need to act at 3 different levels. We need to act at the micro level, that is at the person level. We need to modify our approach to the person in order to facilitate the multidisciplinary, a comprehensive approach. We need to act at the service level, the so-called meso level. So we need to reorient our services in order to facilitate the communication among different experts, different actors in the care of the individual. And we need a macro level intervention. We need to act also at the system, because we need policies, we need regulations that may facilitate the integration of competencies and the delivery of an integrated and coordinated care for the older person. We cannot integrate care for older persons, we cannot work on intrinsic capacity, and we cannot promote healthy aging if there are not consistent actions at all these 3 levels. So integrated care, implementing care for healthy aging, is mainly reflecting the continuum of care that geriatricians have always been trying to force in the management of older persons. The need is to reorient health and social services, 2 sectors that very often do not talk each other. We want to bring them together because we want to have a person-centered approach, and very often the needs and priorities of the individual are not only in the health sector, but may also go into the social aspects, and we need a coordinated care. Again, and if you can see in this slide, also the objective is to optimize functional ability. If you read again between the lines of this definition of integrated care for older persons, you can see many concepts, again, that are talking to the expertise that geriatricians have been gaining in the field of frailty. We are looking here at abilities, at capacities. We are talking about multidisciplinary care, a person-centered approach, and at the need of giving a follow-up and a consistent continuum of care with the evolution of the individual. So the background is there, but potentially rewarded in a different way. After the document on how to implement integrated care, the WHO published, this is 2019, a handbook, a guidance specifically targeting the health and care workers at the primary health care level. As I said before, by acting at the primary health care level, we are working in the context, in the setting that is specifically devoted to prevention, where preventive activities are most meaningful. And at the same time, we are reinforcing, strengthening the filter between the community where the person lives and the clinical setting, the hospital, where we do not want the person to arrive. And we are all aware about the detrimental consequences when the person very often is inappropriately hospitalized and institutionalized. So there is the need of reinforcing the primary healthcare setting. And this is done by training the workforce working there, the health and care workers. So not only the clinicians, but also non-clinicians and persons that may support activities there. There is an hard version of this handbook. There is also an app that may provide support in the definition of the needs, priorities in the delivery of a personalized care intervention. And again, the handbook is based on the concept of intrinsic capacity. We find again the 6 domains translated into the clinical manifestations when these domains are impaired. And so we talk about mobility limitation, malnutrition, vision impairment, hearing loss, cognitive decline, and depressive symptoms as those capacities that are needed to be screened, detected, and assessed and managed as a first approach when meeting and having a contact with the older person. In this document, we have a screening tool that is organized according to these 6 domains. And for each domain, there are very simple questions and tests that can be administered also by a non-clinician, also by technical individuals, in order to facilitate the identification of the problem outside of the clinical setting, and also take benefit of all the opportunities that may be present in the health and social sector for identifying early signs of impairment in order to apply as soon as possible preventive and therapeutic countermeasures. I would say that this screening tool may resemble a sort of frailty instruments simply organized per different criteria, simply structured according to a biological background that is based on the 6 domains of intrinsic capacity. Screening is not everything. We should not screen just for the pleasure of screening. Screening is the first step of a specific care pathway. After screening represents the so-called step 1. If a person is identified as presenting an impairment in one of or more of the 6 domains, then it is necessary to conduct a person-centered assessment in the primary healthcare setting, the so-called step 2. What does it mean? It means that after the screening is positive, the screening for one or more of the intrinsic capacity domains, then we need to look more in depth. We need to measure the severity of the impairment, confirm the result of the positive screening, and try to understand the underlying causes, both by evaluating the individual, assessing the underlying diseases, taking into account the risk factors, and also by looking at the environment, the social and physical environment where the person lives. In other words, we need a comprehensive assessment of the individual. After we have gathered all this information related to the clinical conditions of the individual, his capacity, and the environment, then we are in the position of following into the so-called step 3. We are, that is, in the condition of developing a personalized care plan according to the specific needs and resources and priorities of the individual, eventually ensuring referral to specific services, including geriatric outpatient clinics or geriatric clinics, with also the engagement of communities and support to caregivers. In other words, as a geriatrician, I would say that this structure may resemble a light version of the graph that I was showing before: screening, frailty, comprehensive geriatric assessment, and follow-up and monitoring. That is the common work conducted by geriatrician, but this is a light version for primary health. This is something that may start disseminating the geriatric competencies, geriatric activities at the first level, at the first opportunity, at the first access of care that the older person may have close to where he lives. So potentially disseminating good clinical practice. And this is just an example on the cognitive domain. What I showed you is the generic framework that is presented in the handbook. For cognition, for example, there is a question about memory complaints. There is the screening mainly for based on orientation in time and space and the capacity to recall the 3 words. If the screening is positive, as I was mentioning before, then we go into the assessment of the cognitive capacity. We want to be sure that this positive result is indeed a positive result. And for this purpose, we can use instruments that we commonly use in the clinical practice and that general practitioners at the primary healthcare level may start considering for their patients. There is not a specific tool that is recommended. Of course, there are validated tools that should be prioritized always, but the choice whether MOCA or MMSC or the Minicog should be used for this purpose is really relying on the resources, on the competencies, on what is already available in the field in that context to facilitate the implementation of this framework. Again, if the cognitive impairment is confirmed, then there is this handbook, this guidance is guiding the health and care worker in the assessment and management of possible underlying conditions. So there is a sort of checklist. Please, you want to verify the nutritional status of the individual. You want to verify whether there is delirium. Look at the prescriptions of the individual and whether there is an history or eventual problem with cerebrovascular diseases. And every action is also accompanied by a specific intervention, because as you may recall before, we have guidelines that are linking the intrinsic capacity domains to specific interventions. In this case, multimodal exercise and cognitive stimulation. And again, there is the guidance drives the operator through the comprehensive assessment of the individual by raising alerts on what should be seen, what should be carefully considered in order to explain the impairment and provide coherent possible solutions. All these concepts, all these activities have been tested, and the results were published in 2020 in this report, the so-called findings from the ready phase, where the activities for the implementation of integrated care for older persons at the primary healthcare level were pilot tested in different regions, in different countries and contexts, in order also to understand the feasibility, the barriers, the enablers. Overall, there is an heterogeneity in the readiness to welcome these changes, but there is no absolute preclusion in doing this. Of course, time constraints, resources, the training of the personnel are relatively common issues. But if we want to reorient care, we need to work on this. If we want to improve care for older persons, we need to identify these barriers and address them as soon as possible. And this is the first evaluation, I would say the baseline evaluation, in which we have made objective the integration of care services for older persons, and this will be monitored over time when this approach will be scaled up across countries, and this is already occurring across the globe, in order to measure, monitor, and verify the progress over time, over this decade of healthy aging. Just going towards the conclusion, I want to solicit your attention to the so-called decade enablers. I told you before that the decade of healthy aging is a collaborative effort, and we have 4 action areas. We also have 4 enablers that talk a lot to geriatricians, and again, talk a lot to persons who have been working on frailty. First of all, we need to build capacity and nurture leadership to take appropriate actions, integrating care across sectors. And this is to us, this is to the geriatricians, this is to the geriatric workforce. We have the competencies for facilitating, promoting, and supporting this process. We may become the trainers of the distant future generations of care providers. We cannot accept anymore to be the care providers of older persons, this single task, because there will never be a sufficient number of geriatricians around the world for the exponentially increasing number of older persons. So we need to create some other persons with competencies on geriatric medicine, potentially working as filter between the community and the specialistic care. We need to connect stakeholders around the world to share and learn from the experiences of others. We will achieve healthy aging across the globe only if there is a federation of all those that have today experience and interest at working on older person and aging. We need to listen to the diverse voices and enable meaningful engagement of stakeholders. This is talk to us as soon as we have always been listen to the priorities of the older person in order to adapt care and adapt our interventions. And we need to strengthen data, research, and innovation to accelerate implementation. This is a major issue. I mean, older persons are very often invisible in research, in randomized controlled trials. We need evidence. And as geriatricians, as researchers who have been working in geriatric medicine, we have a lot of data that may support the reorientation of care, may support this shift of paradigm. And these are just some examples on how the enablers are put in place today. In Kuwait or in Botswana, so in countries that are not visible in terms of geriatric expertise, there are the few geriatricians that are today involved also with the support of the WHO in training health and care workers at the primary healthcare level in order to provide first level adapted care for older persons. And this taking into account the heterogeneity of context and resources. Again, adapting models that are very similar to what we have been proposing for frailty, multidisciplinarity, coordination of care, focus on capacity, person-centeredness, in contexts that may be lacking of basic resources. Isn't the need of thinking outside of the box, having a very clear structure in front of us. Research on intrinsic capacity may be fostered by also the availability of data in our geriatric centers. These are results coming from a cohort study present at the University of Toulouse in France, where data collected as part of comprehensive geriatric assessment have been able to operationalize intrinsic capacity and generate these kind of nomograms reflecting the intrinsic capacity decline with aging, somehow approaching the model that pediatricians have been using with their growth charts for the detection of children who do not grow up in the normal way. The same might be true for us in the next future with the concept of intrinsic capacity, checking the decline, the physiological versus pathological decline of intrinsic capacity. And this is another study that was conducted in Barcelona. There was a program built several years ago by Marco Cesari and his team for supporting primary healthcare physicians in the management of frail older persons. They have been able to simply reshape the ongoing activities and by using the data, the activities already in place, they have been able to nest in their research production and in the field activities also the concept of intrinsic capacity and integrated care for older persons as promoted by the WHO, without changing really a lot, because the two concepts, frailty and intrinsic capacity, follow very close and consistent directions. So in conclusions, we need to find a solution for having care systems that are responsive to older persons and might be sustainable over time, especially in low and middle income countries where there is a lack of resources in the delivery of basic service for care. But at the same time, those are the countries that we need to look at, because in those countries there is the majority and there will be the vast majority of older persons around the world. We need to reorient services. Now we can do it as we have always been doing by talking about frailty, but please consider that today there is an opportunity of working with the same concept, with the same approach, by benefiting of the umbrella and the endorsement that the WHO is giving to our activities, simply rewording them under a more positive concept and inclusive concept of intrinsic capacity and healthy aging. In this context, as geriatric workforce, we are in a privileged condition for promoting and supporting this change of paradigm, and with our support, it will be easier to train the current and future generation of care professionals and decentralize and improve care for older persons, also supporting the so-called aging in place. Thanks a lot.
Thank you, Matteo, for a great presentation. There are a few questions. I have questions too. And please, to the audience, if you have any additional questions, please add them to the chat feature of WebEx. Let me start with the first question that I see here. Matteo, are findings related to intrinsic capacity being integrated into public health policies and programs? You mentioned some of them, of course. And then what barriers exist to implement these strategies at the community or national level? I'm sure that's a very long answer.
Well, I can say that we have at the WHO, we have many countries interested to the concept of integrated care, long-term care, and of course, intrinsic capacity. We have training programs that are conducted on a regular basis upon request of the Ministries of Health, and we are also disseminating material for supporting this. There are the countries that today are more asking for support by the WHO in this area are countries in really low and middle income countries, because high income countries have already their models. They already have geriatricians, they already have frailty clinics and connections that are facilitating the integration of care among the different stakeholders. The problem are low and middle income countries, and the rapid and exponentially aging of their population is really worrisome, and we need really critical rapid actions. This is the request that is coming. We need to simplify in order to implement strategies that are feasible, sustainable, but I think that there is a huge opportunity for us to grow in visibility as geriatric workforce.
Another question more about frailty, but I think closely related to intrinsic capacity, and it's about the language. The use of the research language and clinical language is required to overcome the stigma gathered in the expression frailty. I guess there is, of course, a lot of research language when talking about frailty. I guess intrinsic capacity can avoid that issue now, like a new concept.
But you know, I mean, I was mentioning before about the COVID pandemic. I mean, in Italy, at a certain time, ventilators were allocated on the basis of chronological age. There was, I mean, a huge protest by geriatricians, and they said, okay, let's talk about frailty. They took, in the emergency department, they adopted the clinical frailty scale, and without following the instructions, they simply translated it into a sort of visual analogic scale of frailty, and who was frail then is out, without thinking at what is behind, which is the real correct methodology for applying this instrument. This is just an example to show that frailty is out there. It is a very appealing term, a hot topic, but the problem is we need the competencies for correctly tackling it. Otherwise, we are just reinforcing in a politically correct way the stigma on aging.
Another question, and yeah, definitely the ethical implications of what happened during COVID are prominent, and I think deserves another big discussion. From Ben Seligman, thank you for an interesting talk. While I realize the conceptualization of intrinsic capacity differs from frailty, how is its assessment actually different from the frailty or frailty indices?
No, I think that the 6 domains of intrinsic capacity, I did not mention here, but I mean, the 6 domains of intrinsic capacity, again, physical, the locomotion, cognition, psychological domain, undernutrition, hearing and vision, are domains that were resulting from a systematic review of the literature. In that review, the domains were identified as domains associated with the onset of disability in older persons. So compared to frailty, the frailty phenotype and frailty index, the domains were generated on the basis of the existing literature and closely linked to the concept of disability. Compared to the frailty phenotype, we have multiple domains represented in intrinsic capacity because, for example, there is the cognition that is not present in the frailty phenotype. And compared to the frailty index, instead of working on a quantitative evaluation of the accumulation of deficits, we are trying to give a qualitative nature of the domains that are assessed, because for each domain, we have an intervention that can be directly linked, facilitating the translation from the detection of a deficit into a clinical action.
Well, I guess it's more a practical question about do you consider translated ICOP in different languages and implemented it in primary care? That's one of the questions.
Yes, so the WHO has 6 official languages, and the ICOP handbook is available in those 6 official languages. There are also additional languages that have been, other languages that have been added over time. And if we look at the translation, we also see the interest that there might be in countries that are not so visible, in low, especially low and middle income regions, that are showing where the interest for this is. I think, for example, there are translations in Vietnamese, there are translations in Polish, in many countries that are starting to implement activities for the promotion of healthy aging that may not be visible in the usual literature.
And I have final question from Dr. Bouchan, actually from Morocco, that is one of the countries probably in the low and middle income group. And the question is related to the previous question, Matteo, but I guess, and that's a very interesting question for me too, is that about adapting tools to cultural context, because some of the questions may be, developing
Absolutely.
European populations, how to adapt them to another culture that may not do the same activities.
Absolutely, this is a critical question because the WHO talks to the entire world, and we need to consider that large part of the evidence is coming from US, from high-income countries. So what is in the products, in the technical documents of the WHO is is trying to provide recommendations that have a global validity. So the instruments that we find there have had can be considered as globally valid. At the same time, the WHO produces technical products that may represent some global standards, but the contextualization to the specific context, to the local context, is a critical action to take. When we conduct training programs in a country on how to integrate care for older persons, we present the handbook, we present the scenario, but then we work on how to adapt that standard to the local context, because priorities, needs, resources may change. And at the same time, we want to give value to everything that is already in place in that country in order to maximize the opportunity for integration and implementation. So this is extremely important to consider. ICOP is a standard, but then we need to apply it and adapt to the local context.
Thank you again, Matteo, for a great presentation and for the Q&A, and was very illuminating as usual. And thank all the participants for joining us for this Frailty Seminar Series, and we hope that you'll join us for the next one in June of 2024. We'll give you the details soon through our different social media channels. Thank you again.
Thanks a lot. Thanks a lot to everyone. Thanks a lot, Jorge, for the opportunity.
No,
have a good evening.
Take care. Bye-bye.